we don't have as much data with male breast cancer, but under the microscope and the genetic alterations doesn't care if you're a man or a woman, okay? We're going to be looking at this from a genetic standpoint, okay, from a molecular standpoint, and we're going to treat it that way. Now, there are some differences in the way we treat men and women with breast cancer in terms of their hormone pills. In women, we use a different anti-hormone pill in older women than we use in men. That pill in men is not as effective as we like. So we use the old-fashioned drug tamoxifen in older men, okay, which we wouldn't do in women because the tamoxifen is more effective because of the way male hormones work as compared to female hormones. Well, you're going through a lot, right? This is not easy and it's unusual, and so you've got a lot of people kind of telling you, what do I need to do and how do we get you well? The reason you're here today is to discuss what we do after surgery, okay? So surgeries remove this. It's intuitive to think if it's out, I don't need to do anything else, but we know statistically that patients can have this breast cancer show up in other organs long after they've had their original surgery. And there are many things that can predict the risk for that happening, and there are things we can do to reduce that risk, all right? So we know some things about you, and there are some other things we don't know about you, okay? One, we know that your cancer did not seem to involve any lymph nodes, okay? And that's good. It's intuitive to think if the cancer had gone into the lymph nodes, that you'd be at higher risk for this coming back, okay? We know that the size of your cancer is about 1.8 centimeters. Now this is big enough to put you at some risk for this coming back, okay? But not everybody with this size tumor has an aggressive tumor that needs aggressive therapy like chemotherapy. Some patients can take milder treatments to keep it under control, all right? We also know that your cancer was fed by estrogen and progesterone, and that it was not fed by something called HER2. These are all good. The cancers that are fed by HER2 often will need aggressive chemotherapy type regimens to keep them at bay. These tumors can be treated with a pill to block their growth, okay, but sometimes still need chemotherapy, all right? So in the old days, if I saw you 20 years ago, I would say, well, we're not sure, but because of this size, maybe we better give you chemotherapy to keep it away, even though we knew many of those patients didn't need it. We now have another test called the Oncotype test that helps us differentiate those patients who need chemo and those who don't. And what they do with that test is they take your cancer that's already been removed from you, okay, you don't have to do anything. We send that cancer for more evaluation, okay? So we did all this stuff, but now we gotta do more. And we don't do this to everybody, only to these patients like you. For a little bit bigger, fed by estrogen, we send it off to the lab to do a special test to look at 21 different genes associated with breast cancer recurrence. It's different than the genetic test you had done to tell you whether you carried something. We'll talk about that in a little bit. This is looking at the genes that the cancer has acquired. This is not what you're born with. It's what changes these cancer cells have undergone to misbehave, all right? And some patients have an aggressive profile and some have a less aggressive profile. And we're gonna look and see if you're high risk or low risk. In these low risk patients, there's no benefit to taking chemotherapy, all right? The pill is all you need. In these high-risk patients, there's up to a 50% reduction in the risk of the cancer coming back by taking chemo. So there's a big gain here. So we'll send the test off. We want to have a low-risk tumor, okay? But if you're high-risk, at least we'll know those patients are going to be the ones who get the most bang for their buck by taking chemo.
Hello, it's John North here, March 18th, 2024, with an update on my breast cancer journey. Back in end of October, November, when I first saw the oncologist, I had hoped that I would not need chemotherapy. As it turned out, the Oncotype test they did indicated I did need adjuvant chemotherapy to prevent or to help prevent cancer from coming back at some point later. So my first treatment was December 7th. I had a total of 4 treatments, medication called docetaxel, and the treatments were 3 weeks apart. I had an allergic reaction to the first treatment that caused me some pain in this clavicle area of all places, and also in my lower back and knees. They treated me with Benadryl and resolved the reaction. The 3 treatments subsequent, I got Benadryl before they started the treatment and didn't have any problems. Side effects of the chemo were, I had some nauseous feeling, but not severe, never to the point of actually getting sick. Mild discomfort with, kind of tummy issues, and nothing major. The biggest problem I had with chemo was fatigue and muscle pain in my muscles, particularly in my thighs, the big muscles. And I'm still in recovery from that. 6 weeks out from my last treatment, I'm still dealing with weakness and sore muscles, particularly in my thighs, my calves, and the biceps are actually getting quite a bit better these days. So I have to say, chemo was difficult. It was definitely not an easy thing to get through, but I did get through it, and I'm coming out the other side and beginning to feel better. Doctor says recovery is going to take, full recovery will take about 6 months, and I'll get better little by little as time goes on. And the best advice seems to be to be patient.